Agitation is next, and we just had JACO come by late last year, and every year they come by and they're triangle visit, and they look at some of these definitions I'm getting ready to go through with you guys. Sedatives are commonly used to treat anxiety and agitation, and believe it or not, anxiety and agitation are recognized as two different phenomena because they are. Anxiety being a state of intense apprehension, uncertainty, and fear, something that we've all experienced, and certainly probably if you've been rounding in the MICU, as I have been over the last 2 or 3 months, that can be a routine experience, even for your own self. And then agitation, a state of anxiety accompanied then by the motor restlessness. Okay, so somebody lashing out, if you will, whether delirious or not. I believe this next stat is under predicts the reality, but up to 70% of patients experience agitation in the ICU. I believe that number to be significantly higher than that, and it's a shame because 70% is already a pretty distinct majority. Why do I bring up JACO? Well, over the years, it's not uncommon to see physicians enter orders to treat both anxiety and agitation. And very rarely are you going to have one drug that is truly meant to treat both. When you look at anxiety, that's probably something more along the lines of a benzodiazepine, and I very rarely would recommend benzodiazepines outside of, say, something like alcohol withdrawal syndrome or some form of seizure activity. But and when you get into agitation, probably linking as a bridge to delirium, that's where I would consider more of an antipsychotic, like haloperidol or quetiapine schedule or something along those lines. We'll get into some of the other drugs here too. All right, I hope this one is correct. I do have this teeter-totter backwards on some of these presentations, and I should have checked it before getting in here. Sedation is a tough balancing act. None of this is easy because there's so many components intertwined. Let's see if it works correctly. I can't remember. It does. If a patient becomes oversedated, some of the sequelae you can see here, and even if this is the goal, which right now it does seem to be more of a goal in COVID and certainly in non-COVID, but a patient who's oversedated, you can run into, again, that enhanced immobility. So what do you expect? Pressure sores, pressure ulcers are not out of the question. DVTs, right? That could lead to beyond that. Muscle atrophy, going back to remain, especially with the late weaning being next, muscle atrophy can be certainly in the smooth muscle that we control, as well as the other areas that tend to be more asymptomatic. Go back to mentioning the dynamics of a diaphragm that becomes paper thin. The inability to assess neurological function, which this could be a big deal if you're consulting, neurocritical care for some reason or neurology in general. They'll get quite frustrated with us if it's something beyond a metabolic disorder leading to the ability to do drugs, something you hope you can reduce. And then increased cost. And I don't mean increased cost from the drugs being used a longer time. I mean, that will certainly play a role, but I'm looking at it more from a increased length of stay. An ICU day, an ICU bed can easily get into $15,000 to $20,000 a day with all the interventions that could happen, if not more than that. The drugs that could be used, but just to have an ICU bed is I still want to say around $10,000 or $11,000, $12,000 a day. Management of the ventilator can easily get to around $1,500 to $2,000 a day. So it adds up fairly quickly. Under sedated. I will say this one tends to happen less frequently, I feel like, but it's quite real here. Anxiety and agitation, as we've already discussed. Hypertension and tachycardia, again, for that fight or flight phenomenon, same with myocardial ischemia. Wound disruption is very real. It tends to happen more so downstairs than in the SICU, where you might have somebody who just recently had an exploratory laparotomy and they were sewn back up. And if they throw a fit, sometimes that wound can disrupt, which can get very interesting very quickly. Patient injury, and then our injury as well. I have nurse and MD here, but I will emphatically state that pharmacists touch patients too, and we should be. And I would be lying if I told you that I haven't been hit unintentionally and intentionally over the years in trying to get somebody basically quelled, if you will. But certainly nurse physicians, you guys are at the highest risk there. What's the goal? Patient comfort and ventilatory optimization for those remaining on the ventilator. When you look at the guidelines, they suggest maintaining light levels of sedation. We'll talk about some studies that have challenged even light levels of sedation here coming up. imminently. Next slide or two. Why? Well, this is associated with improved ICU outcomes, so decreased length of stay, both ICU and hospital, and shorter time on the mechanical ventilator. You do see some increased physiologic stress with this, but there's been no association with that increased physiologic stress in any form of myocardial ischemia. Now, please keep in mind that if you have somebody who has a very poor baseline cardiac function, it may be different. But overall, this is the stance and the interpretation of the data that have been published. The association between death of sedation and physiological stress remains unclear. This is to say that, just because somebody is deeply sedated doesn't mean that they aren't having some form of psychological stress, okay? And there's no great way to assess this. And frankly, the best way to avoid this would be to literally put somebody in burst suppression, which would not be a routine recommendation, right? So the guidelines recommend to titrate sedation to light rather than deep levels unless contraindicated. For example, if you're mechanically proning somebody in ARDS, especially if they are mechanically paralyzed, they need to have deep level of sedation. As far as interpretation of this, here's oversedation in the ICU. This is a study of 274 medical patients, combined two studies, where they found that 32% of the patients were completely unarousable. 21% had no spontaneous motor activity at all. Very little variation in level of consciousness, motor activity, or drug exposure over a 24-hour period. When the nurses were queried on this, they only 2.6% of the staff found them to be oversedated. The bar graph down on the bottom helps capture some of it as well. When you look at this, it should be disturbing to see that the levels of sedation assessments completed were as low as they were over the course of practically 1 week. And then when somebody followed up through and looked at deep sedation, the majority of the patients across the horn were deeply sedated. Now, these are older papers. 2007 is almost ancient history at this point. In fact, when you look at critical care literature, 2007 is ancient history. But it doesn't get away from the emphasis that you have to assess your patients as well. I will say overall, our nursing colleagues are nothing short of phenomenal in the MICU. And I can promise you that there would be nowhere near a number of only 2.6% of our staff saying that they were oversedated. But still stuff to be mindful of. Sedation and brain function monitoring, you want to use the most valid and assessment tools. We use the Richmond Agitation Sedation Scale, or RASS. That's why it's bolded here. The Sedation Analgesia Scale is available as well. It goes in the reverse order of numerology with the intense observations of sedation. The suggestion of BIS or bispectral index has got further and further away. There was a time where we used BIS more routinely, especially in chemically paralyzed patients, whether they were prone or not. We're not doing that much anymore. So do not use, and certainly in patients who are non-comatose and non-paralyzed. It can be used in patients who remain neuromuscularly blocked. I will say it's nice to get a baseline before starting it. I will tell you that very rarely do we get a baseline before starting or use of ABIS in patients who are under neuromuscular blockade. EEG activity can certainly be used to monitor non-convulsive seizure activity. There have been some interesting data published in the last 5 or 6 years to suggest that the rate of non-convulsive status epilepticus, in particular in the medical population, is probably much higher than most of us would want to hear or certainly claim. But it's there as a method as well. And of course, at our institution, we have the liberty of doing continuous monitoring, and we have enough machines to look at a fair number of people. That's certainly a blessing in our realm. Go back, the name Curtis Sessler, here it pops up again because he helped develop the Richmond Agitation Sedation Scale. So as you can see here, it goes from a score of -5, which is completely unarousable, no response to voice or physical stimulation, up to +4, which is combative, overtly combative, and a danger to you and to themselves. Goals, again, it depends on what you're trying to accomplish. Having just rounded with Dr. Zafar last week, he does a great job making the resident think about what you want your RAS goal to be. And it is something that you should think about beyond pressing a dial button on the Epic order, because if you get into the order set, it makes you choose a RAS range, and whether that be -2 to 0, -1 to 1, or I think -1 to 0 is a range. I'm a person, I like a 3-point spread in range. I think that's more, it's just more mobile for the nurses to do what they need to do. Uh, as you can see here, -1 to 1. This ranges from not alert but sustained awakening to anxious but movements not aggressive or vigorous. There are times, if patients are in their more acute phase, I might do -2 to 0, and then -2 just getting into light sedation. Briefly awakens with eye contact to voice in less than 10 seconds. Remember some of these scores, because it's going to be prudent with some of the studies that we talk about coming up. One in particular, note that -3 is actually moderate sedation. All right, so movement or eye opening to voice, but no eye contact. Sedative choice. Strategies using non-benzodiazepine sedatives such as propofol, dexmedetomidine, I'll throw ketamine in there as well, may be preferred to benzodiazepines. The language around benzodiazepines has really gotten negative in the last 10 to 15 years. There's improved clinical outcomes in mechanical ventilation, and that has been shown time and time again. Regardless, the choice should be driven by patient-specific indications and goals, clinical pharmacology of the drug, and then, yeah, I will mention you have to think about overall cost associated with particular sedatives. I hate to mention this, there probably is a number 4 here, which is availability. Drug shortages right now, as I mentioned, are very real. It's something that we evaluate literally every day to help optimize delivery of analgesia and sedation to our critically ill patients. As far as looking at benzodiazepines versus non-benzodiazepines, here is a forest plot from the guidelines that capture really favoring non-benzodiazepines, and by the skin of its teeth, if you look at the 95% confidence interval there, 0.03 to 1.1. So literally by the skin of its teeth, primarily driven by this study by Rich Riker in 2009. It's in JAMA, if you're interested. It's called SEDCOM, SEDCOM is the mnemonic for the study, comparing midazolam to dexmedetomidine, where dexmedetomidine was found to actually decrease mechanical ventilation time and enhanced time to liberation from the ventilator. Another big study out of these, not that I want to necessarily say that they're not all big studies, but the group in Vanderbilt, Pratik Panharapandi, published what's called the MENDS study, MENDS, in 2007, also in JAMA. It did not show a increased time to liberation. But nonetheless, it's still nice to look at. It's always good to look at heterogeneity. An I-squared statistic of 13% is pretty darn reasonable. So this is what helps guide some of these recommendations. As far as pharmacology, here's your sedative pharmacology. You're looking at your benzos, the top 3 first, and then propofol and dexmedetomidine. Keep in mind ketamine. Also a decent sedative, but was in the previous section. What I want to highlight here is you are going to see variance in the onset after a loading dose. The elimination half-lives vary. There's differences in active metabolites. There's even differences in, say, if you look at lorazepam and diazepam, they're both suspended in propylene glycol, where midazolam is not. So you could end up running into issues with propylene glycol. As you see, diazepam, propylene glycol-related acidosis can occur. That can happen with diazepam as well. Overall, you're going to see hypotension with all of these agents in certain variations. Propofol is another interesting drug where you'll notice it has by far and away the shortest onset, 1 to 2 minutes. The elimination half-life changes dramatically, though, when you talk about, again, in infusions, where the short term, the half-life is around 3 to 12 hours, but long-term use, which is, say, somewhere beyond 48 hours, 50 plus or minus standard deviation of 18.6 hours. So pretty significant. As far as adverse effects with propofol, outside of hypotension, respiratory depression, you can't get hypertriglyceridemia. In fact, if you use the sedation order set as it's intended, there is a baseline triglyceride that should be checked, and then one every 48 hours after that. We have, at least I have, loosened up my criteria of when to be concerned. If it gets above 400, I will at least send off an amylase lipase to assess whether the pancreas is doing okay. But given some of the confines with COVID, myself as well as several colleagues around the country, there was a big topic about this in a critical care listserv, are willing to go all the way up to a triglyceride of 1,000 before stopping the drug, pending we have enough supply to use. You got to be mindful of propofol-related infusion syndrome, which can look a lot like septic shock, where you certainly have acute multi-system organ dysfunction. You can get acute kidney injury, hypotension, Downstream, you can get myocardial depression that can become quite severe, by all means. So just be mindful of that. Sometimes it's good to send off, even a CK in situations like that if it's suspected. I will say I've heard a lot of excitement over the years over green urine. I love the fact that green urine is identified, but you're not looking at something that is sensitive nor specific for propofol-related infusion syndrome. Dexmedetomidine, it's a good drug. It's not a great drug, in my opinion, but it's a good drug. I sometimes see it overused, in my opinion. I don't bolus all that often. Keep in mind, this range that they show here is the FDA-approved range from the drug. Studies have gone up to doses significantly higher than 0.7 micrograms per kilogram per hour, and we have two ranges. One range is 0.2 to 0.7. We also have another range that you can select in EPIC to go up to 1.5 because that's as high as they went in SEDCOM. Side effects, bradycardia and hypotension are very, very real here. And they happen, I think, more frequently than people are willing to give it credit for, especially if a bolus is given. But you're looking at a drug that can be preferred. It's more of a wakeful sedative, and it is great for doing what I would call dextubation, where if you have a person who has high requirements or remarkably agitated, and that's their limitation of their mental status to get liberated from the ventilator, dexmedetomidine is a drug you can use to help tame that agitation or exaggerated requirements of other pad pharmacology and facilitate extubation. Works out to say dextubation. I just wouldn't write that in the note. For what it's worth, ketamine can be used the same way. Ketamine can be used and maintained on native airways. But I would still say if you extubate somebody on either one of these agents, you should have a plan to get them off fairly rapidly thereafter. As far as agitation therapy goals, you want to get depth and quality. Sedation should be routinely assessed, just like pain, so greater than 4 times per shift. Target lightest level of sedation possible and or use daily sedative interruptions. A spontaneous awakening trial, if you will, that may be paired with a spontaneous breathing trial, if you want to call them as such. Sedation protocols are key here, checklists to facilitate management. And as you heard me mention before, you do want to do an analgesia first, sedation if you can for intubated or mechanically ventilated patients. So I told you guys there's a trial coming up that I want to discuss, and this one's fairly hot off the press. If you notice, the publication date of March 19th of this year. So finally, this was a non-COVID related study. That was nice. Called the NONSEDA Trial, done out of Denmark. So the question here is, if light sedation with interruption reduces mechanical ventilation time and ICU length of stay, what about no sedation? Which is kind of an interesting concept, and I won't lie to you, it still makes me a bit uncomfortable. But what you have here is a multi-center randomized controlled trial that looked at patients with no sedation versus what they called light. And I put light in parentheses because they had a goal of RASS of -3 to -2. Remember, -3 is actually moderate sedation. And there's a big difference between moderate sedation and light sedation. Okay? So one would argue that perhaps the better way to have executed this study was to compare it against, say, -2 to 0 or even -1 to 1. Primary outcome was 90-day mortality. You can argue with both this study and another study that I want to show with dexmedetomidine, the SPICE trial, that mortality is probably not the best primary surrogate for a lot of critical care studies, especially 90-day mortality, but that was their choice nonetheless. Secondary outcomes looked at major thromboembolic events, ventilator-free days, coma and delirium-free days, ICU-free days, and incidents of acute injury. They ended up including the 710 patients overall, but 700 patients were included in the modified attention to treat analysis. What did they find? No difference in 90-day mortality. Okay, 42.4% in sedation versus, 37% in sedation versus 42.4% non-sedation. I'm actually surprised with 700 patients that an absolute difference of 5.4% wasn't a little bit closer, or certainly wasn't a little bit lower in the p-value range. They had no difference between ICU or ventilator-free days, no meaningful clinical difference between coma or delirium-free days. And then there was an edge in major thrombotic event differences where non-sedation had 1 versus sedation had 10, which if you look at the percentiles there, it's 0.3% versus 2.8%, 95% confidence interval. You can see there does not cross 0. Now, I'm careful interpreting this to change my practice because while they call it light sedation, they were aiming for moderate to light sedation, -3 to -2. So I'm not surprised patients who were moderately sedated probably were less mobile and ran the risk of thromboembolic events, major or otherwise. So be careful translating some of that and taking it away from this. But this is a study. I was kind of surprised to see it in New England Journal of Medicine. but I think the pressure is there nonetheless. Moving into a study with dexmedetomidine, also out of NEJM from last year, the SPICE-3 trial. Excuse me. Aim of this study looked to evaluate dexmedetomidine effect on all-cause mortality in 90 days. Here we are looking at mortality, 90 days again, versus usual care in mechanically ventilated patients. Population was mechanically ventilated patients for less than 12 hours, expected to continue or receive ventilator support beyond the next calendar day. This was a multinational study that was open label, so keep that in mind from a strength and weakness standpoint. It's kind of hard to perhaps do it otherwise, I guess. Randomized, and it was controlled. So you could have had dexmedetomidine as the primary or sole agent versus usual care, being propofol, midazolam, and that was their translation. I don't know that I would call midazolam usual care, but it's there nonetheless. Outcomes: you had rate of death from any cause at 90 days for your primary, secondary 180-day mortality, coma or delirium-free days, ventilator-free days at day 28 after randomization. Again, I struggle a little bit with 90-day all-cause mortality as a surrogate because I'm not sure that the sedative choice you choose in the first couple days or maybe even first week plays that much of a role as a independent risk factor to influence death 3 months later. That's just an ism for me. Be aware of that. I won't even get started on 180-day mortality. But you have to choose something, I suppose. So here is a table breaking down what they found with dexmedetomidine, usual care, and then you have your odds ratio and then your adjusted odds ratio thereafter. There was no difference in death from any cause at 90 days, all right, to suggest that dex, there's no certainly benefit in mortality, 29.1%, so at least we'll call them moderately sick, critically ill patients. Death at 180 days, again, barely any difference there, certainly not statistically significant by any means. Median number of days free from coma or delirium. You can see there, again, only a 1-day difference. And remember, so when you look at delirium free, more is better. And then ventilator free days, again, no difference. So, which was actually a little bit of a swing away from what was found in studies 10 to 12 years prior. Looking at other side effects, I wasn't surprised by this one. Dexmedetomidine was associated with more bradycardia and hypotension, as well as what was defined as serious bradycardia and serious hypotension, and even prolonged sinus pauses. Now, you look at this, and you're talking about a study with almost 4,000 patients. There's these are secondary outcomes, so there could certainly be some overpowered phenomenon to this. But I still think taking away, you have 0.5% of patients versus 5.1% of patients, or even 0.05% versus 0.7%. Those are some pretty serious differences. So if you're a purist and you decide to do a number needed to harm with these values, given that they were statistically significant, you'll find that these are not extremely high numbers when you consider how much dexmedetomidine we have certainly used over the last 2 or 3 years. Adjunctive and algo sedation. These slides are a bit self-serving if you look down at the citation. This was a paper that my Paige Garber, now Paige Bradshaw, this was her PGY2 critical care pharmacy resident project. I precepted her on it. Got it published last year. This was a retrospective 2-center study, so it was between us and Westchester, of 104 patients mechanically ventilated, and mainly the SICU. There were some patients in other areas, but mainly the SICU. And I guess that should be a SICU. Impact of low-dose ketamine continuous infusions as adjunctive analgesia and sedation. What we wanted to look at was a % relative change in concomitant analgesia and sedative doses at 24 hours after ketamine is initiated. And what we found, and yes, you could argue catching culture here, I get that. What we found is with most agents, even 12 hours after, significant reductions in all medications overall, but in particular propofol. By the 24-hour mark, maintained reductions in propofol, reductions in fentanyl, and overall, and that panned out all the way to the 72-hour mark. And this was while maintaining RAS and OPAS goals. So ketamine was used as a sole agent, as an adjunctive agent that helped reduce the amount, if not eliminate, the amount needed by patients while maintaining goal ranges and score ranges for different areas, whether it be analgesia or sedation. Agitation care bundles, very similar as the prior slide. This is really a loop between assessing treatment and prevention. Again, I will just stress that if patients get over sedated, you want to back off quickly, perhaps turning it off for a brief time and then starting back at 50% of the dose. And just be aware of the tool that you're using to assess sedation and what your ranges and goals are. Delirium. Increased mortality with delirium. That verbiage has been softened in the most recent guidelines because that's really been single center. If not, if it's more than a single center, you're talking about still observational studies. So maybe not the best to be to lack bias in assessing mortality when you're doing an observational study. Prolonged ICU and hospital length of stay is noted, and then development of post-ICU cognitive impairment, in particular in ICU, adult ICU patients, but there's even been some suggestion in pediatric ICU patients, what I find to be very interesting, especially when you're largely discussing brains that are still very much in developmental phases. Wes Ely, the name down here, if you're interested in looking at anything that has to do with delirium, Wes Ely is probably the most published name in delirium. For what it's worth, for those of you who have had a chance to work with Duncan Haidt, he trained under Duncan Haidt at Wake Forest several years ago. But delirium, this paper published in JAMA, showing the delirium, if you look at the Kaplan-Meier curve here, to be an independent predictor of higher 6-month mortality and longer hospital stay. Now, I'm okay doing 6-month mortality if you show a longitudinal impact of something. And that's what a Kaplan-Meier curve certainly does. And it doesn't take very long to appreciate a spread between no delirium and delirium and looking at probability of survival. Detection and monitoring, recommended routine monitoring, no different than the other two areas that we've discussed. Utilize the most valid and reliable tools. So we use the confusion assessment method for the ICU or CAM-ICU. There is also the intensive care delirium screening checklist or ICDISC. This one is used far less commonly. I would tell you between the United States and Canada, I think literally 98 to 99% of facilities use the CAM-ICU. However, the first and second author, and really it's not second author, the primary author and the co-primary author, so John Devlin and Joanna Skrobic, and their two centers for the most recent guidelines, they use ICDISC. So ICDISC will persist. Routine monitoring is feasible in practice. This is a test that's done very rapidly. I would encourage you guys to learn how to do it and perhaps even challenge executing it when you're in the ICU. It could be done in a matter of minutes. So you check for acute onset of mental status change or a fluctuating course and inattention, all right? And then you either assess for disorganized thinking or altered level of consciousness, all right? So that's through, you've heard nurses asking, save a heart and having a patient squeeze each time they hear A and not squeeze when they don't hear an A. Asking them simple questions about, can a rock float? Can an elephant fly? Showing them a device that they should know every day, like a pen, and asking them what it is. And this is a dichotomous test. So you're either CAM-ICU positive, suggesting you have delirium, or you're CAM-ICU negative, considering that would suggest you do not have delirium. You have to have a RASS of -3 or greater to execute this test. The patient must have a RASS, sorry. Risk factors, there are many. They fluctuated over the years, but these have stood true as far as 4 baseline risk factors: pre-existing dementia, the history of hypertension, history of alcoholism, and then a high severity of illness on admission, which that's something that's been debated on what that means, but you'll find that that applies to the majority of patients who come into our MICU. Coma itself is an independent predictor, especially if it's non-pharmacologic coma. If you get into some of the metabolic comas, for sure. Conflicting data regarding opioid use and onset, but benzodiazepine or benzodiazepine use, as we've discussed, is certainly there. How there? Well, here's another study. This particular individual, Pratik Panarapandi, also works with Wes Ely. And what they found back in a study in 2006, where this was more routine, that in a 24-hour period, if you were to use around 23 to 24 milligrams equivalents of lorazepam, the probability of transition to delirium, absent of any other factors, was 100%. So pretty significant. Prevention, getting early mobilization whenever feasible, getting around that immobility. That's where the relationship starts to come out, as well as if you want to look at sleep hygiene, that could play a role there as well. No recommendation regarding pharmacologic prevention. There's just not great data that's out there. Yes, you could look at a dexmedetomidine study published in the Blue Journal 2 or 3 years ago now, that looked at use of dexmedetomidine in patients who were not delirious and preventing delirium. That's probably the closest thing we've got. I have the utmost respect for those two individuals. And when I say that, the first author was Ioana Skrobic, and the senior author on the paper was John Devlin, who happened to be, co-primary authors on the guidelines. So their bias was quelled a little bit in making distinct recommendations. There's really not great information out there about haloperidol or other atypical antipsychotics as far as routine use. I mean, there's actually been some data to suggest that haloperidol increases mortality, especially with age and doses used being considered. And I will talk about another, what I consider to be a landmark paper that evaluated these techniques as well. And there's no recommendation regarding combination of pharmacologic and non-pharmacologic treatment. I think here, reanimating somebody, getting them to be human again, is what's most important. And reanimation, getting them up, early mobilization is key in reducing. There's absolutely no published evidence favoring haloperidol treatment in reducing duration or intensity of agitation. We use it all the time. In fact, I would challenge all of you to log into Epic and just go into a patient and try to order haloperidol. You'll notice that you can't just click a button for intravenous because the FDA doesn't recognize it as approved intravenous therapy, yet it's done all the time, not just in our institution, but across the world. Atypical antipsychotics may reduce duration depending on where you read. Again, I'll challenge that with some papers coming up. There's no, when you look at rivastigmine or any drugs in that drug class, do not recommend their use because they've actually been associated with increased mortality. And then, of course, being mindful that many of these agents will increase QTC and can come across as a significant risk with torsades by themselves, let alone the fact that many of our patients tend to be on 3, 4, or even more QTC prolonging agents. So looking at haloperidol itself, it does have a fairly rapid onset, long half-life. We will use it as IV intermittent dosing, although I will tell you with the drug shortages in the world of COVID, we have entertained bringing it out as a continuous infusion. There are papers for that. Adverse effects, you will see a dose-dependent QT interval prolongation. That tends to be more with the IV form. Extrapyramidal symptoms are more with the PO form. And there really isn't a whole lot of respiratory depression with this. You can see it with higher doses that are used. Same thing with hypertension. But with the doses that we tend to use, that should not be all that common. If it happens, it's probably a combined effect of different interventions. So what about antipsychotics? Are they the key? Well, here's a study it was led by Tim Gerard, who's yet another individual down at Vanderbilt, critical care practitioner, great guy. Published in New England Journal of Medicine in 2018. Our own Duncan Haidt was on this paper as well. So randomized double-blind placebo-controlled trial of ICU patients with hyper and hypoactive delirium. Haloperidol, what they did was 20 milligrams IV daily as a max, and then they used ziprasidone, where we tend to use more quetiapine, 40 milligrams daily as a max versus placebo. Primary endpoint was number of days alive without delirium or coma, so something maybe a little bit more tangible, something that's a little bit more pragmatic versus the other studies, where I was talking about the primary endpoints being mortality. And then secondary, here's your secondaries: 30 and 90-day survival, time to extubation, time to ICU hospital discharge. What you'll find is maybe not, right? No difference in primary or secondary analyses between these groups, okay? Whether you look at days with coma, days with delirium, days alive without either one, no major differences. I'm surprised this study has not changed practice more than it already has. Because we're still using a fair amount of these agents now. I'll let the COVID world slide a little bit, but stuff to consider. And then here's this slide again. I would imagine you guys are familiar enough with it now. Assess, treat, and prevent these areas, and just looking at different components therein, they've certainly all been discussed. I'll leave it up there for a few minutes or a few seconds just for you guys to have time to take a look. I'm sure the way that this will be edited, we could also pause. Let's put this all together. All right, so daily sedation interruptions or light sedation levels should be used in patients who are mechanically ventilated, all right, as long as it's within reasonable confines, okay, and as long as they're in that stage of their disease to facilitate and allow that to happen. Promote sleep by optimizing environments using strategies to control light and noise, clustering critical care or care activities in general, decreasing stimuli therein. There's actually no major recommendations on modes of mechanical ventilation. Now, that's not to say that certain modes are more agitating than others. I certainly want to be put on APRV long term. It just looks like a very, very comfortable approach to things, but sometimes it's necessary. Use an interdisciplinary ICU team. There's a reason why we work with you guys. We get the nurses involved, we get physical therapy involved, we get respiratory therapy involved, metabolic support. That's always been shown when we work together to improve mortality, right? Improve outcomes. That includes provider education, exactly what we're doing right now, protocols and order sets, and quality ICU round checklists. Briefly, and that was putting it all together for the pharmacology or just PAD in general. There are several studies out there looking at the efficacy of spontaneous awakening, spontaneous breathing trials. This is one that I like. I edited this presentation to try to cut down on time, and I removed several others. But this one here I'll keep in. It's the ABC trial, also led by Tim Gerard. So yet another study out of Andy, looking at the safety and efficacy of that approach, and then looking at ventilator-free days, duration of mechanical ventilation, length of stay, duration of coma and delirium, and then long-term neuropsychological outcomes. Here's what they found, looking at SBT versus SAT with SBT. Ventilator-free days, keep in mind that more is better. Statistically significantly different there, 3 more ventilator-free days in total. Looking at time to events of successful extubation or liberation, shorter in SAT with SBT. ICU discharge was 4 days difference. Hospital discharge was 4-day difference, all of those being statistically significant. Death at 1 year, again, I'm a little, I don't know how much all of this plays a role at 1 year. I struggle with that a little bit. But it was lower nonetheless in this group, in the SAT SBT group. And then looking at days of brain dysfunction. So again, now lower being better, lower with coma. I'm a little surprised to see a p-value of 0.002 with 1 day, but that just comes down to power and statistical dynamics. But can make a difference. So conclusions. Again, Gene and all you guys, I'm so appreciative of the opportunity to do this. I hope this was informative. I hope it wasn't too long or boring. And like I said, if needed to be breaking into 2 parts, I could appreciate that. But you want to consider pain, anxiety, and delirium as causes of agitation. The goal was to assess, treat, and prevent. Use validated tools. And I'm hoping as an institution we switch to a validated pain assessment tool here shortly. Pain control always first with light sedation levels if needed, assuming that that's appropriate. Incorporate routine daily sedation interruptions, again, if appropriate, and then keep it interprofessional for best outcomes. All I will finish with, guys, is everybody's doing amazing work and making amazing sacrifices with what's going on in the world right now. And you guys are certainly no exceptions. And I would just encourage you guys to be safe, take care of yourselves, take care of your families, do what you can to minimize your risks of contracting this virus. Hopefully we're getting close to being over the hump. We'll see. I feel like projections are changing every day. But thank you guys. You don't hear this enough. Thank you guys for what you do and what you're doing in the care of these patients. Obviously, the medical side is taking the brunt of COVID-19, and you guys, best I can tell, are doing a spectacular job in giving these patients the best chance that they have. And it's probably going to be some of the most difficult times we all have, I hope, as practitioners. So if you guys have any questions for me, feel free. I mean, you can let Gene know. Many of you have my number. Feel free to text me, or you can email me. My email is my first name, full first name, Christopher, and it's CHRISTOPHER .Droege, DROEGE @UCHealth.com. I'd be happy to entertain any questions or facilitate any discussions that may further enhance your understanding of this process. Enjoy my other colleagues and their presentations as well. With that, I have nothing else for you unless Gene has any specific questions.
Hey, Chris. No, that was fantastic. I think I need to process some of this information before I ask a lot of questions. I will try to make a area where they can submit questions easily, and I will let you know as things pop up. This was amazing.
Again, thanks for the opportunity. I know it probably even went a little bit longer than I thought it would, but